Great. Hi, this is Vinod Thourani. I'm one of the cardiac surgeons from Emory University in Atlanta, Georgia. And it's my pleasure today to moderate the roundtable discussion from the 50th annual meeting of the Society of Thoracic Surgeons. I have an extremely esteemed faculty here, and we'll start off with Dr. Ailawadi and just for some introductions.
Hi, Gorav Ailawadi from the University of Virginia. I'm a cardiac surgeon.
Vinay Badhwar from the University of Pittsburgh.
Mike Argenziano from Columbia University Medical Center.
Right, so our topic today will be mitral valve repair versus replacement, and really what are the indications for different pathologies of mitral valve disease processes and how really this esteemed faculty will attack or really go after these problems. So Dr. Argenziano, I want to start off first with you and just tell us a little bit, as you know, the CTS network of which we were a part of, along with you and the other groups, has recently published a paper from Dr. Acker in the New England Journal of Medicine talking about ischemic mitral regurgitation, severe ischemic mitral regurgitation, repair versus replacement as a randomized trial. So I think most people know what the results are. Can you just summarize in maybe one or two sentences the results, and then can you tell us how this has impacted your practice?
Sure. The trial was a randomized trial, as you know, comparing patients, enrolling patients who had severe ischemic mitral regurgitation. And the real question is, if you randomize those patients to repair versus replacement, how does that impact outcome? Now, the main outcome measure was not survival or really any clinical endpoint, but rather left ventricular volumes. That endpoint showed no difference between the groups in the final analysis at a year. However, the difference that's been all the buzz has been one of the secondary endpoints, which was the incidence of recurrence of significant mitral regurgitation, which was much higher in the repair group than the replacement. It was 32.5% in the repair group and only about 2% in the replacement group. So really what most people are taking away from this trial is that although the follow-up was relatively short-term at a year, that even at that time point there was a significant percentage of patients who had repairs who had recurrent MR.
So Mike, so when you see a patient now, and we'll go through the whole panel, when you see somebody now, are you just replacing their ischemic mitral, are you replacing their mitral valve in ischemic mitral regurgitation? I mean, or which patients are you repairing and replacing, having known the data?
That's a good question, and the trial, of course, was conceived specifically because this is a huge question and a big controversy in our field. There are as many surgeons who feel that repair is superior in every case as there are who feel that replacement is safer and more predictable. Frankly, in my practice, I was leaning toward replacement already before the trial because especially when you're doing a complex procedure with multiple valves and say coronaries, et cetera, the uncertainty of a repair that might need to be redone or may not last is often a problem. I will tell you that I have not changed my approach specifically because of the results. So for instance, last week, a day or two after we published the paper, I did a patient like this, and I did a repair because in that patient, the pathology, the ventricular size, the morphology, et cetera, to me, lent itself to repair. So I guess my bottom line on this is that the trial looked at very, very granular, very, very non-specific categorization of ischemic MR, all ischemic MR patients with tethering, et cetera. I think that surgeons who do mitral valve surgery know that there's a lot of different types of patients within that group. And so I think the patients with certain characteristics are still better off with a repair.
Vinay, can you give us a little bit more granular detail? Are you looking at tenting area? Are you looking at EF? Are you looking at age? Tell us a little bit more granular, or tell our constituents really, what are you looking for?
So again, this trial, exactly as Mike said, it's all about granularity. So there's granularity on the type of pathology in terms of tenting. It's also the granular type of repair. And when do you add adjunctive techniques to your approach to ischemic MR or IMR or functional MR? So I would say that if of all of the aspects, it's ventricular size and the tenting depth.
So are there specific numbers? So do you say an LV of greater than 6, you're going to go more towards replacement, or a tenting area less than 1.5 centimeters, you're going to go towards replacement?
So in terms of the tenting depth, I would say if you're more than a centimeter, if you're more than 10 millimeters, then I think as restrictive annuloplasty alone probably is not going to cut it. However, there's a lot of patients that we've all seen, probably the case that Mike did the other day, the tenting height was probably 5 millimeters or less. And the coaptation point was pretty much annular based. So there's not a whole lot of tenting, but the patient had moderate to severe central functional ischemic MR. The other issue is viability. And in patients that have myocardial fibrosis that's diffuse, we have to think long and hard, is that patient going to truly remodel? But if I was to say size versus tenting height, I would lean on tenting height before size.
Okay, great. And also, Vinay brought up viability. So I do commonly in IMR patients, I'll get a cardiac MRI on those patients and really look at whether the inferior wall is viable or not. And if it's not viable, and there's a 1 to 1.5 centimeter tenting area, I'm more likely to replace those patients. So I agree with you. Gorav, can you just tell us a little bit about your thoughts of the IMR?
So I think the study really showed us that there's ultimately two groups of patients in the repair group. There's a group, 70%, that actually had a very good repair and 30% that did not. And the question is, how do we distinguish those two? And that's really where we're at with ongoing analysis of that study, and we hope to see those results soon, which will be very beneficial. To this point, I think in terms of my practice, our bias has always been to repair whenever possible, particularly with ischemic MR. And I think this study has at least opened our eyes to say, you know, it's okay to replace it if you think you need to. And the other part of it is that we haven't really touched on is the technique for replacement is really a total chordal-sparing replacement, which is oftentimes not taught to many of us in our training. And so I think that's very important to emphasize. You really need to preserve every chord to have the best outcome. In terms of who I select for replacement, I look at the patient and see how sick they are, how complex a surgery. I look at their EF, their tenting height, and their end diastolic volume. And if to me they seem to be a pretty ill patient who I suspect may not even live more than 5 or 8 years, where maybe the benefit of repair would be beneficial, but they may not make it that long, then I would be more attuned to replacing that patient.
Okay, thank you very much. So I want to jump around a little bit here to low ejection fraction mitral regurgitation, be it degenerative, be it ischemic, be it any type of the variety of mitral regurgitations. EF of less than 20%, 25%. Gorav, let's start off with you. Tell us a little bit about how are you approaching this patient. He comes into your office, 76-year-old executive who now, for whatever reason, EF of 20, 22%, severe mitral regurgitation. How are you handling those patients?
So I think you really have to do a pretty thorough preoperative investigation, particularly in terms of the mechanism of MR, what their size of the LV, what their RV function looks like. I oftentimes get a right heart cath on those patients, and it's particularly helpful if you know this patient had a better EF or a normal EF even up till a few years ago, so you have a better idea. If they look pretty functional, pretty active, fairly robust, I would offer surgery as a first-line therapy, even though there's some debate, particularly in the cardiology literature, whether there's how much benefit there is with surgery. And then in terms of repairing or replacing, it goes back to our previous discussion. Now, if they seem a bit frail or their pulmonary pressures are exceedingly high in the 80s or 90s, then I would consider alternative options like MitraClip, which we'll discuss in a bit.
Sure. So, Vinay, tell us where is we've all been talking about the heart failure teams and the heart team in itself. Tell us where a heart failure team falls into this scenario.
Well, I think it's very germane for these types of patients because there's really a couple different types of patients that in your question. So there's the degenerative patients that have really just not been seen thoroughly, and they come late and they've got very fixable pathology that just have a low EF. And then there's the primary ventricular problem patients that actually happen to have functional mitral regurgitation. I think they're two separate categories because I think you can potentially fix the valvular problem and fix the secondary ventricular problem, perhaps, provided there's no end-stage fibrosis per our earlier conversation. In the latter group, that's the sweet spot, I think, for the heart failure team, where it includes interventional cardiology, heart failure cardiology, all around pretty much what the COAPT trial is really trying to show. And discerning, as Gorav nicely, eloquently said, about the preoperative workup. And if these patients have really fixed disease and bad ventricular disease and or their frailty assessments or STS risk scores are very high, then alternative therapies are good. Otherwise, getting a collaborative approach, and that includes, resynchronization therapy, heart failure optimization, readmissions to optimize their volume status and diuretics, all those go into play because you can sometimes change the needle on these patients preoperatively, and then you have a different patient that you have to decide upon.
Absolutely. And, you know, we've talked about the heart failure service that looks at LVADs and heart transplants, and we'll talk about transcatheter aortic valves, and we see as a heart team, I think we really need to get to a point where we're seeing mitral valve patients together with the team also, not the straightforward 55-year-old with P2 prolapse. I'm talking about everything maybe besides that.
What I would add to that is just that I think we have to be careful about what we mean by heart team. Right. Because to this point, with coronary and now aortic valve disease, we have kind of, operator-dominated, teams, both surgeons and interventionalists working together, which works great. But for this specific problem, for the problem of mitral disease, which is so much more commonly associated, as you explained very nicely, with ventricular disease, I don't think it's good enough to have the MitraClip interventionalist and the surgeon involved, because the real key partner, as you mentioned, is the heart failure cardiologist. And one of the issues is that the heart failure cardiology, philosophy over the last decade or so has been operate less and treat more medically,
exactly right.
which of course has been very helpful to many patients. The last thing you want to do is operate on a patient who isn't optimized or for whom the mitral is not the main problem. But I guess what I'm saying is, at least at our institution, we've had some difficulty, moving the needle within the heart failure cardiology community, because their paradigm is still, medical treatment.
Right.
If I just add one comment, I think it's very important. What the point Mike's making is the non-proceduralist component, and I think I would also add a proper cardiovascular imager.
Yes.
In our Center for Mitral Valve Disease, that's exactly, because there's a very big difference between a good TE done as an outpatient procedure in a different hospital and one done by someone that's what he does all the time.
You're absolutely right.
I would also just take that a step further. So we, a lot of these patients are usually a heart failure cardiologist will see as an outpatient. If we get to the point where we're going to offer therapy, whether it be percutaneous or, say, a more aggressive surgical approach, that patient will get admitted to the heart failure service a few days ahead of time and get optimized, oftentimes a repeat heart cath, make sure their EDP isn't through the
Especially to look at the RV. I think you have to look at the RV in these patients also.
I think a lot of the morbidity is in the RV, and I think that's important.
So, Gorav, talk to us. We're going to segue a little bit into the MitraClip. You've had a lot of experiences, as some of us have, and I know Mike has had some from the original trial. Tell us, what patients should we be doing a MitraClip on now?
Okay. So currently, as you know, the FDA has approved the MitraClip for patients who are at exceedingly high risk with degenerative valve disease. And so if we take those patients, I think every one of those patients should be evaluated by a surgeon.
Even if they're an STS score of 3, even if they're an STS score of 4, a relatively moderate risk patient, you still want us to do that pathway?
I think the surgeon needs to determine that, because as you know, there are things that are not in the STS that are critically important, whether they've got a porcelain aorta or they've got cirrhosis or a very high pulmonary pressure. There are certain reasons that the STS doesn't assess, including frailty. So I think it's important that the surgeon is involved. On the flip side, there are patients who are a very healthy 85 or 90-year-old with a degenerative valve that a lot of people would say, really, you're going to operate on that? Well, yeah, you can, and you can have probably a pretty good result, particularly if you can offer a robotic or less invasive approach to that patient. Now, in terms of functional MR, we had up to this point the ability to treat high-risk patients through the Realism trial. That is since completed, and currently we're in the COAPT trial, which is randomizing medical therapy to patients with functional MR with MitraClip. Where surgery falls in is still a bit debated, and goes back to our previous discussion. I do think surgery still has a role, although the ACC guidelines are still evolving whether or not that's an appropriate therapy. And I think that remains to be seen down the road, how effective MitraClip is versus medical therapy. What we don't really have is a MitraClip versus surgery arm in those patients right now.
Great. And Mike, any comments about the MitraClip?
Yeah, and I think the MitraClip, we've had lots of experience at our institution, and frankly, I think the story that I like to tell, which really illustrates where I think it fits in, is that we were doing, through Realism, a fair number of MitraClips in really just extremely sick patients you just wouldn't want to operate on. The kind of, I call them the two French door patient, where you have to open the second door to your office so that the wheelchair and the oxygen tank can come in. Those are the patients that we were referring to Realism. And then there was the moratorium and the recall on the device, which lasted about a year, and that just shattered us. I mean, I wound up operating on patients that were such high risk that we really did not, even consider operating on before. So we really saw it in our clinic. We saw, literally dozens of patients over, the course of that year who really lost the opportunity to get a clip. So even though that's the most extreme example, I do think that it has a role in high-risk patients.
2014.
In 2014, I think there are plenty of high-risk patients. Some of the things that you mentioned, radiation, previous surgery, patent grafts, calcification of the vessels, et cetera, those are all good reasons to consider that alternative.
Great. Vinay, you want to make some comments before we go to the next topic?
Well, I would just say that, being a COAPT investigator, as all of us are, I think there is equipoise. Yeah. And I think we will find out from this trial what the answer really is, I would hope. And I think, we're all mitral zealots, right. And we all have our thoughts on the clip. But I think with any new device, I think this type of trial is very important to discern exactly, is it the two French door oxygen tank toting grandmother, or is it the dilated myopath person that's frail, that has a poor 5-minute walk test, 5-meter walk test? Is it that person? Because I'm sure we have all done patients in our trial experience that have done well.
So I guess I just want to make one more plug. I do think as surgeons we need to be heavily involved in the COAPT trial to the extent where not only are you evaluating, but you're putting the devices in, because there's a lot of trepidation with a lot of surgeons out there about MitraClip and what it's going to do to their mitral practice. And we all know there are many patients that we never see with mitral disease, and so I think we're just seeing the tip of the iceberg when it comes to surgical patients. But if we as mitral valve surgeons are the only ones that have all the tools, MitraClip, minimally invasive, sternotomy, robotic in some cases, so you have all the tools, I think you're going to make the best decision.
And this is very analogous to the transcatheter valve era, where I say that surgeons need to be trained in transfemoral, transaortic, transapical, and we need to be able to do the same. So our constituents, we feel like all of you should find some way to get experience with these newer technologies, and the Society of Thoracic Surgeons is looking towards finding ways for you to do this. So Vinay, can you comment a little bit about training? What if someone comes to you and says, or what would you say to our constituents, what's the best way to get trained in more complex mitral valve? It's very difficult for any of us to go away for a week or 2 weeks or even a month or 3 months to go watch somebody operate or take a mini fellowship. So you just give us a little glimpse of what you would see an educational forum down the road for our constituents.
So I think, mitral valve disease is not going away. I think despite all of the concerns of what cardiac surgery as a specialty is doing, this is a natural disease, and it'll be in the realm of cardiac surgeons for the foreseeable future, despite the improvements in MitraClip. So first and foremost, before you embark on the phase of minimally invasive or minimal access surgery and then robotics, I think the first thing is to be a competent mitral surgeon.
Open sternotomy.
Open sternotomy mitral surgeon, P2 resections, sliding valvuloplasty if necessary, or at least triangular resections, Gore-Tex neocords. Get an experience and get a bottom denominator. I think that number should be probably 50 cases of open sternotomy mitral degenerative disease. Once that's achieved, and the next stand position from there can be mini sternotomy approach or directly to mini thoracotomy if the surgeon's comfortable with the peripheral perfusion platform. Following direct vision, minimal access, and that could be a little bit larger thoracotomy if you need to.
Sure.
The key is no deficit in outcome of mitral repair. Right. And then track your own outcomes, match it to STS and peer groups. Videoscopic is the next approach, which is a smaller thoracotomy incision, non-rib spreading, and then finally robotic. Right. Each stage of the pathway following consistent outcome of mitral repair.
I absolutely agree with that. I think you have to take it stepwise, and I think that's probably the best way to have outcomes. In our short period of time here, I just want to ask the group here, do you have to do it robotic for it to be the right thing? Personally, I do minimally invasive, but I don't do the robotic, and so I've kind of stayed away from that. So I think the constituents need to hear which way we do it and which way is an okay way to do it. So let's start off with you, Mike.
Yeah, so we were involved in the original robotic mitral valve trial. We were the second highest enrolling center, and actually that's how we got into minimally invasive mitral valve surgery. This is in the late 90s. So we actually had never done minimally invasive surgery, and in fact did some mini thoracotomies in preparation for the trial. And as you know, that trial used a mini thoracotomy approach with robotic assistance. It was not a totally endoscopic operation that was done. And now, of course, there are people that are doing a much more endoscopic operation with a robot. We do 300 minimally invasive mitral valves a year, but we do not use the robot anymore, haven't for a decade. For us, our ability to provide complex high-level mitral valve repairs of all kinds to patients through a 3-inch incision has really kind of become the standard in our region. We don't find a patient or referring doctor pressure to go beyond that. And frankly, in my opinion, I think that that's one of the things that drives all of this. I mean, I think even minimally invasive surgery, if you think about it, it's driven by patient preference, by surgeons' willingness and attempts to keep the operation desirable. So all I'm saying is that when I still, because of our reputation, I still get hundreds of patients a year that come to me asking for a robotic operation, and it takes me about 30 seconds to describe how I do it. And once they understand that the only difference between a robotic operation and what I'm doing is the 4 small incisions versus 1 larger incision, and specifically we cannulate the patient centrally through the mini thoracotomy. So we do not use peripheral cannulation. When you describe that versus a peripheral cannulation robotic operation, it doesn't take more than a minute for patients to understand that you're delivering what you can in the best way you can.
2 quick answers, Vinay.
So we've followed the spectrum I just outlined, and we have now gone to robotic as pretty much a standard. But we have done exactly as Mike had outlined, several hundred of minimally invasive, video-assisted, small incision mini thoracotomy approaches with peripheral cannulation, with 100% safety record, no bad outcome, and then we introduced the robot as a pretty much our new standard at this point.
Perfect. Well, go ahead, Gorav.
We're at the stage where we're performing any isolated mitral through a port access video assisted. We have not undertaken the robot. One other thing I wanted to touch on about the training is it's important to involve your entire team.
Yep.
And that's very critical to making sure you have good outcomes.
You're absolutely right. This is a team effort. I personally do minimally invasive mitral valves, but Doug Murphy, one of my partners, is has one of the largest series in robotic mitral valve surgery, and has done a phenomenal job with that. So we kind of do both. I guess at Emory, in our 3 hospitals, we do a little bit of both.
I do want to emphasize, that you have to look at every patient, and you don't need to push yourself to do a minimally invasive case on every patient.
That's right.
And there are some patients that are ill, and you just want to get in and out quickly, and it's okay to do a sternotomy in those patients.
We all still do sternotomy.
Yeah.
Absolutely.
Every day, very regularly.
So the last question before we leave, it'll just be a number. In 5 years, we'll start off with Gorav, since you just ended here. In 5 years, Gorav, what % of patients will be done through transcatheter mitral valve repair or replacement? So some of the stuff that Mike Back talked about at TechCon at this 50th anniversary meeting. Just a number.
There's a lot of patients you're talking about here. So repair, degenerative, I would say less than 10%.
Okay.
Repair functional with a MitraClip or other percutaneous device, I'd say 25%. Replacement, I think, is longer than 5 years away. I think we'll be in trials in 5 years, and so maybe in 10 years, in mitral replacement, we're talking about maybe similar type of numbers, 10% for degenerative, maybe 25 or up to 50% for functional if the results are good.
Okay, that was a lot of numbers. Okay, Gorav. Vinay, sorry.
I know it's hard.
It's hard with the 3 of us, that's right.
Actually, I would agree with almost those numbers. I would say degenerative low.
Degenerative, we're saying about 10%. Michael, see if you agree with this.
I would say low.
So degenerative, we're saying transcatheter
Less than
mitral,
10%.
less than 10%.
Yes.
And then we're saying in higher risk functional ischemic type of, we're looking at 25 to 50%?
Yep.
Is that what I heard?
fair.
We're thinking, so we're saying potentially 50% in 5 years
No,
will be
you're saying
transcatheter?
50%.
25 to
Well, what I'm
50%?
saying, the key area here is that in the functional realm, okay,
Right.
the fact of the matter is that that's where surgery doesn't have a stellar record.
Right.
Okay, even if you can, and remember, it's not just high-risk patients. There's also patients at high risk of a bad outcome. Right. That is, you could be a low-risk patient, meaning that you'll survive the operation. But if you've got some of those characteristics we talked about earlier in terms of tenting height and everything like that, your operation is just not going to work. And so that's an operation that shouldn't be done. So I think a lot of the functionals are going to go the way of percutaneous repair. I don't think there's going to be much progress with degenerative repair, but I do think that replacement is going to potentially be the biggest area because I think that if you can replace a valve percutaneously and essentially get it to land and stay there, then it's going to be hard to argue that that's not a good alternative to an operation.
So,
And I do
Vin-
think the
what-
denominator is different, though.
So,
The denominator is a lot
would-
bigger than what we know for functional MR because
Absolutely.
we don't see that. So
So-
I think there's room
So
for
Vinay,
everything.
last word before we close the session. We could be here for another couple of hours. I know the SDS doesn't want us to be, but last word about this, and then we're going to wrap it up.
I think that our members should not be fearful about the encroachment on our surgical control of the mitral space. That I think it's, as Gorav said, it's still infantile in the product development, that percutaneous approaches are here, they will stay, but they will have a finite role for the non-leaflet-based pathologies.
Great. So I'm very honored here to be on a table with three esteemed colleagues of mine, and this has been a very exciting, and I hope you've enjoyed the session on mitral valve repair versus replacement. And again, thank you so much, Gorav, Vinay, and Michael. And signing out from the 50th anniversary meeting of the Society of Thoracic Surgeons, thank you very much.
Thank you.